Very good morning to all. Am I audible? I welcome you all to the second webinar of 2023 from BOCI. And today we have a very good topic to discuss and to know many things about it. And let me introduce the speaker of today, our guest, my dear friend, Dr. Mahantesha. Mahantesha is working as an associate professor, Department of Periodontics, Faculty of Dental Sciences, Ramaiah University of Applied Sciences. He has finished his master's in periodontics in 2008 from MS Ramaiah Dental College, and he has obtained fellowship from International College of Oral Implantology, USA. In addition to the rich academic experience, he is a renowned researcher. He has been sanctioned a grant by Indian Council of Medical Research, that is ICMR, in the year 2020 for its project on dental implants. He has won numerous awards for paper presentations on national and international platforms. He is credited with 2 patents to his account. One is for the toothbrush sanitizer, and the one more is for analgesic coated surgical suture. He has also delivered numerous guest lectures and conducted several workshops on lasers and implants. He has well over 30 publications to his credit in national and international journals. He is the first person in India to be authorized to conduct clinical research on soft tissue augmentation material around dental implants for BioHorizon company. And that's really great. He has received training from digital technology in implant dentistry and conometrics concept in implant from Scotland, UK, and advanced dental surgical protocols associated with Royal Association of Oral Implantologists, USA, by Dr. Jeddak. I welcome you, Dr. Mahantesha. It's an amazing to have you here. And I think I request all the participants to keep your questions typed and send it in the chat box so that we can take the questions in the end. And I request all of you to mute once you join in, because there's a lot of disturbance which is happening if you have kept it not muted. And with that, I can say it's over to you, Mahantesha, please.
Thank you so much, sir. It's my privilege to present topic in front of you, because you are my teacher, guide, and you are my inspiration, icon, in fact. So most of the things, whenever I want to do something new, I always keep in mind. Sir will so much effort, and you will do a lot of research. I always think of you because you are my UZ teacher, and still we're in contact with each and everything. And I'm really good, the follow of yourself, sir. And I always follow your footsteps, and I want to see you in different level. I'm already seeing you, but still, and it's my privilege to present my little bit of work on the implant maintenance. And when you gave me this topic, I was really happy to say this, because most of us will place an implant in right and left wherever there is a bone. We never bothered if the bone is not there in the oral cavity. We'll take the support from adjacent area like zygomatic, pterygoid, somewhere which is away from the jaw, but still will place an implant. But the least importance is given for the maintenance. So let me tell you about my experience. Yeah. When I published my first article on the dental implant maintenance in 2011, I didn't know much about the importance of maintenance. So we in books, we already read about what are the instruments we need to use to clean our implant, how to brush, and what all the methods are available, and so many very narrow, what you can call it as the spectrum of, we didn't get much material, and not much of research is happening over the implant maintenance, how much has happened in implant dentistry. So this was what I gone through, but we always know in UG and PG, we always teach how to brush and how to maintain. That's it, nothing more than that. But after taking this topic as a webinar topic, then I've gone through the many articles. So much of research is happening in implant maintenance. It's almost equally how is going to happening in the implant dentistry for this, or like surface modification, about osseointegration, so many things happening. And same way, even maintenance also is happening along with the implant. The first question comes, the patient comes and asks you, what guarantee on implants? Dr. Saab, I'm paying so much of money. What is the guarantee of this? So this question is most of the implantists question means will face this question from the patient, because definitely patient is paying so much of money and he expects guarantee. And as of now, once this comes in front of us, we always start thinking, what is the best answer to give you? Yes, we can say, I've done so many of implants, there is no failures, but patient asks evidence. We keep it in mind, then you'll go to searching some kind of articles. Then we always give, see, so many articles published and so much of evidence is there. Around 95 to 98% of success is proven. So what about 5 to 8%? That is so many factors involved in that. Now we start how there is a success and what are the factors involved in the success of implants. Then so many things comes in mind. Those are all, so start from the local factors to the system factors, so the habits, the condition of periodontal health of the patient maintenance, and so many, the technique, what you use for the implant placement, so many things comes in mind about success. This all we always, in implant practice, day-to-day practice, we always keep concentrating on these factors, but least practice on the implant care. The implant care, it starts once you place an implant, once you're loading it. From the day one, the post-operative care is the most important for the success. We should not neglect, after placing a beautiful implant with engaging the so many bones, the bicortical engagement is done, so much of gaussian integration, you've got a very good torque, and you've given a beautiful zirconia crowns with a nice emerging profile. This is all from our side, but patient has to give importance to that, whatever the process he has, and the start, that day one you load that implant, whether it's immediate load or a delayed load, the day you loaded implant, the maintenance protocol starts. But as of now, there are no concrete protocol for the implant maintenance. Everything is going with like one-on-one. Okay, this is the best method to do it. This is the best method to do it. So many things we should keep it in mind when you want to give the instruction to the patient, and patient has to listen to that. So who is responsible for the maintenance? Either a dentist or hygienist or patient, or who is responsible for the implant maintenance? See, anything happens to the implants, definitely patient, the implant company may, okay, this is a fracture of implants, okay, this is because of that. So many things we can do it, but processes issues, okay, that is our fault. But maintenance, when the time comes for the maintenance, it's all our responsibility, including the patient, the dentist, the hygienist, everyone is responsible for the maintenance. How? The maintenance protocol starts from the dental office. Basically, because patient will not be knowing, it's not freely available how to maintain implants. Even being a dentist, we also didn't know before joining the dentistry. And after placing implant, then patient come back to us with mucositis, periimplantitis, all this kind of the issues. Then you start searching into what could be the reason and what went wrong, whether it is because of placement of implant or because of issues with the keratinized tissues, or if it's lack of the tissues, or patient is not maintaining properly. So many things to start from there. Then you start keep assessing what exactly and what is going wrong. Then this maintenance starts from the dental office. That's most important is we always neglect in that part, but we should always give an importance for the implant maintenance. That's most important for the long-term success of implant. Because once you place an implant, the patient will always keep it in mind. After 10 years, 15 years also, they'll come back to us. Dr. Saab, aap kiye the, aise ho gaya. See, this we should not, take responsibility that. So that is our duty to say that education, motivation about the implant maintenance. That's also play a major role in success of implants. So after this, there is a beautiful article published in 2020 in Clinical Oral Implants and Research, that's patient perception of implant therapy and maintenance. It's a questionnaire-based survey, and it's really eye-opening study for us, how we are motivating, how we are educating the maintenance, that's maintenance phase in implant therapy. So they almost assessed around 522 patients at the age of 61 years. So here, what they found in the result, around 91.2% of participants declared, yes, the doctor explained me about the maintenance. He just told me about how to brush and how to maintain, what are the brushes you have to use, what mouthwash you have to use. But no one taught me in the dental office. That makes the difference. We always tell over the face, we always tell over the counter, yes, they take this brush, they take this paste, you have to brush two times a day and come for the checkup after a year. If any issues, please give me a call. But that is not a way to start up our maintenance phase. So around 40% of people, then they told, yes, doctor is given a demo and they showed me on the dental chair how to maintain it. This makes a lot of difference. This is what we need to practice in dental practice, in the implant practice. The reason behind that, because they'll not be knowing how to hold the brush, how to brush these individual implants or multiple unit of prosthesis. This makes a lot of differences in practice. That's the concluding the study is, yes, around 60% are only the 60% of people will go without knowing what to do after implant placement. They could not maintain their teeth. Because of that, they lost their teeth. Fine. If you don't reinforce or if you don't tell about how to maintain the implant, that's also go for toss. That's also end up with the periimplantitis and implant failure. So this is most important thing we need to consider when you're placing the implant and when our post-implant therapy is the post-implant maintenance. If you don't demonstrate, they'll do how they used to do. That's because a lot of things are changed in maintenance therapy. This I'm going to take you in detail about the what paste, what brush, what techniques, all these things I'm going to in detail about the implant maintenance, individual implants, multiple implants, straight implants, tilted implants. So many things are involved in that. If I don't demonstrate, patient will not brush it properly and definitely end up with poor oral hygiene. It means lot of calculus and plaque accumulated in the oral cavity and in and around the implant, below the prosthesis, and ultimately end up with perimucositis. Then you'll end up with the periimplantitis. And still, if patient don't come back to us for a checkup, then end up with loss of the bone around the implants. End up with we need to go for explant. That's the only thing is left for us. So now where is the problem lies? The problem lies in the dental office. We need to educate, we need to motivate, we need to demonstrate about the implant maintenance. So once the implant maintenance is good, when the peri-implant mucosa is good, the peri-implant soft tissue is good, then there will be no problem and success we can expect better than non-educating the patient. If you come to the peri-implantitis prevalence, this beautiful article published in 2022, all the implants journals, what I'm taking is from the standard journal. And this recent article about the prevalence of peri-implantitis, a systematic review and meta-analysis, what they concluded that the result they found is the prevalence of peri-implantitis was around 19.5, that's around 20 in the patient level, and around 12.5 to 13% in implant level. I hope you know about the patient level peri-implantitis and implant level peri-implantitis. I'm not going in detail about that concept. But what it says that still, even though there is good amount of technique, good amount of bone is left, but so many things are there, but still there is a failure rates. That could be the reason of that. Now the periodontal maintenance play a major role in this. The question comes is the peri-implantitis more faster than periodontitis? Definitely, because if you understand the differences between the dental implant and as well as natural teeth, they're totally different. You know why? Because if you see these similarities, if you see there is a dental implant in one side, the right side, and the dental means that natural teeth, the root is on the left side, you can see there is a lot of differences in the attachment as well as the vascularity. So in implants, there is lack of connective tissue attachment. This hypovascular, there is no vascularity from the periodontal ligament space. Fine. And there is not much of, there is a defense cells. Definitely is lack of so many cells which is present in the periodontal ligament area. The regeneration capacity, defense cells is less. So that's why the attachment is not so strong compared to the natural tooth. So when this kind of attachment is expected in implant dentistry, so definitely tissues also, or whatever the cells are also weaker in defense mechanism. So we should be more careful. Even little amount of the plaque accumulation also leads to the perimucositis. So apart from the attachment, the what material you're using, fine. So when there is a root, whatever the changes in the pH, whatever the material, whatever the drinks, whatever the food habits is there, it won't affect on the roots. But if you use any kind of the drinks, which is altering the pH of your saliva, if you're using some kind of the mouthwash, which is having the fluoride, which so many things is affect on the implant, because the implant is a metal, it's made up of the metal choice, and there are certain times, most of the times when there is chances of the releasing the titanium ions also, that also is effect, that's also directly or indirectly leads to periimplantitis. So you should be more careful when you you should give more importance when you have an implant about when related to the plaque control or overalizing. Implant care is the same as like a natural teeth? Yes, it's the same, but in different method. We're using the same kind of brush, we're using the same kind of mouthwashes, but the component of the brush, component of the toothpaste, the quality of the brush, the design of the brush is different from natural teeth. Because as of now, we always studied so many techniques, the implant, like overalizing techniques, and what are the toothbrushes. In Karanja, they told about the Boss technique, modern Boss technique, Charters method, and Stillman's method. So many methods they taught us to maintain the natural teeth, but there are not standardized toothbrushing techniques for the maintenance of implant, because it's not still, there is no concrete method to do these kind of implants. So there are different techniques, and depends on the patient, depends on the place of implants, depending on the nature of the prosthesis, it varies about the technique as well as the types or design of the brushes. Right? Is it same? What is the brush is using, paste is using, floss is using, internal brush is using? It looks everything similar, but there is a lot of differences in maintenance of implants. You have to choose the proper the shape, the proper quality of the material for the implant maintenance. How and why I'm going to take you in that path. So if coming to the implant maintenance care, the implant patient care, so that it works in two different levels: at home care as well as professionalizing care. At home care, we need to educate and need to motivate the patient in the dental office before loading and after loading, immediately after loading also. So patient has to take care at home, whatever the instructions, whatever the demonstrations you are given in the dental office. The professional care, professionalizing care, definitely patient has to come back to the dental office for the maintenance. That is the how frequently he has to come, when is the ideal time to come. All these things I'm going to take it in. There is certain proposed protocols for implant maintenance. This all we already read in UG and PG level about the brushing. You can use soft toothbrush, motorized brushes available in the market. You can use that. And there are water irrigation, which is a fancy. You can use it for to remove all the debris and food particles below the processes and in the internal areas. And we use internal brushes and flosses to remove the plaque and as well as the food debris. This we already know about home care method, and everyone follows about this. The professionalizing, definitely we all read about scaling and curettage. Here we don't do root planing because there is no root. And here what scaling and curettage will do. And we use subgent irrigations and as well as polishing by using the rubber cup with nano-brush polishing paste, such as aluminum oxide, tin oxide, all these things just to polish that area, make it smooth, and so that plaque accumulation will be less. This is what we read in dental school. Is there any protocol for the implant maintenance? I already told there is no concrete protocol about implant maintenance, because it's not like how the natural tooth is going to erupt and how there'll be embryos space, what is a attached gingiva, what is a keratinized tissues. Everything is planned, everything was organized. It's not like that. In those conditions, if there is a natural teeth maintenance, definitely we read about the various brushing techniques, including the circular method to the circular method. But in implant dentistry, it's not like that. There are certain protocols we need to follow depending upon the type of the implant you're using, depending on the type of the processes you're putting it. Okay, so there are certain protocols. There's one article published in Applied Science in 2021. These are all proposed protocols. As such, there is no concrete protocol as of my knowledge, but most of the proposed protocols, these protocols immediately after loading, delayed loading, whatever it may be, but there are certain protocols are there too. But if you practice those kind of protocols, definitely you can get good result in maintenance. So this article published in 2021 by Periodontist. It's a very beautiful article. What I felt it. This process, this prosthetic rehabilitation have been divided into single crown, fixed partial processes, fixed full arch, and word dentures. Fine. When you're placing implant, you will not place only. This is depending upon the requirement. Sometimes you will use only single implant with single crown. Sometimes you'll use 2 implants or 3 implants, giving the one segment of the processes. Or sometimes you'll use full arch. By there we'll use the parallel implants or tilted implants. So many varieties of position of implants. Right? And sometimes there is no bone. Patient is not willing for the advanced implant surgeries. Then you go for word dentures. They all are different. The method of implant placement, and as well as it's depending upon the requirement. But each and every the processes takes its own way to clean. Okay, so you should always keep it in mind. If the patient is having the single crown, if the patient having the fixed partial crown processes with multiple implants, either fill arch, whether they're tilted implants or parallel implants or dentals, it's not same. Maintenance is not same for every patient. It varies from person to person. How? So this implant maintenance therapy, yeah. In this the proposed protocol that divided the maintenance in the 2 steps, that is ordinary and extraordinary. So there's a type of maintenance is ordinary and extraordinary, and this is done by the hygienist as well as dentist. If it is ordinary protocol, yes, it's done by the hygienist. What they will do is just assess the soft tissue examination and assess for the plaque index, ask for the plaque score, and assess for the plaque probing depth, the bleeding and probing, and just clinical examination. And in this ordinary maintenance, they will not take out any processes. They'll be intact. This is just examination, kind of examination. But if you go to the extraordinary protocol, here it's done by the dentist and hygienist. What they're going to do is they'll reassess all the clinical parameters. Along with that, if it is really required, they have to remove the prosthetic structures and they'll go for the maintenance. So these are the 2 common steps in each patient. Okay. Now we'll come to the individual aspect of maintenance. Yeah. If the patient has a single crown with a single implant, fine. So what is the protocol for this maintenance protocol, this kind of the patient? So we already told there are two steps we always follows for each patient, that is ordinary and extraordinary. So if the patient walks into dental clinic, first the hygienist will check about the soft tissues and about maintenance about in and around that implant. And this usually will recall the patient every 6 months. If the patient has a single implant, every 6 months you have to recall the patient and check and reassess the soft tissue and hard tissue counting, and as well as his implant, as well as his the plaque score. And 2 to 3 times everything is fine. You can recall the patient 9 months interval, and if it's still maintenance is good, then you can call once in a year. If the same patient within a 6 month after ordinary examination, if there is any bleeding and probing is there, then dentist has to pop in. Then he has to remove the processes. Then you have to reassure that, because it's very difficult to treat when there is bleeding and probing and attachment loss is there. That time you have to take out the processes. Then you have to do the thorough management. This is non-surgical management is more than enough when there is a single crown with BOPs +2. There's a next case, if there is a fixed partial processes. So in this, there are 2 protocols I already told, that is ordinary and extraordinary. In this protocol, you have to recall if the patient has multiple implants, more than 2 implants, you have to recall the patient initial stage 3 to 4 months. Again, you have to, the hygienist is going to assess properly about the soft tissue assessment and clinical examination, what all things you have to told. But if there is any bleeding and probing is positive, you have to open it. Otherwise, extraordinarily every 12th month, every year, you have to recall the patient and you have to remove processes and to make sure that you're going to do this local drug delivery, or you can use any kind of the like what you can call it is like oxygenated gels. You can place it in that area and you place the processes back to that, then so that there'll be no destruction going to happen in that area. If the patient has multiple implants, whether it's a short implants or long implants, so here as the protocol, you have to recall the patient every 3 to 4 months, because in these cases the maintenance is little difficult for each patient. And every 6 months you have to remove the processes and you do the cleaning up of that area. This is what the proposed protocol is followed and published in that article. If it's a bleeding and probing is there, you have to recall the patient immediately and you have to reassess that area. And otherwise, every 6 months, you have to recall the patient for the maintenance therapy. The old denture, here, there is no rule of ordinary because patient knows about exactly. So he's taking out the dentures, he's putting it back. And every 6 months, just you have to come to the dentist and you have to reassess, or you have to make sure that everything is clean in that areas. So this is a protocol is published. This is a proposed protocol is published, and this is what is following. And most of the dentists, European countries, following this protocol. And when the patient comes to us, we should give more attention where implants are placed in augmented sites. Because wherever there's augmented bone, it's a scar bone. Right? So in those areas, you should be more careful about that, because the destruction of the bone is more rapidly happening when there is augmented bone. And his patient has a history of periodontitis, definitely, because they are prone for, and the studies is proven that patient has the loss of the tooth because of the periodontitis. Here, more attention is required for as a maintenance therapy. And if the patient has a short implants, because around 6 to 8 threads will be there in the short implants, in the 2 to 3 threads is exposed, definitely the 50% of support is gone. If it is a long implants, like a gigantic implants, tilted implants, very difficult to maintain, they're very difficult to clean. So those implants, you should give more attention for those kind of implants. Whether it's very short implants, you should give more attention. Very long implants, you should give more attention, because the maintenance is challenging in those kind of implants. And complex processes with false gingiva, where there is no soft tissues encountered in that area, and lot of zirconia is happening along with the false gingiva. Is definitely more plaque attention, more plaque retention will be there in that area. So we have to keep in mind, you have to keep thinking about how to maintain the cleanliness, and you should educate and motivate the patient for the maintenance. So most of the times the question comes, what kind of brush I need to use? Is it the same brush, or you have to use a different quality of brushes for the implant? You can use the same brush, but the technique is different. And even we should select, while selecting the brushes also, we should have a lot of knowledge about the angulation of the implants, the position of the implants, what kind of brush will suit for this kind of the patient. That's most important. This is what we never taught in dental school. If you come to the objective of toothbrushing, yes, this is basically to eliminate the bacteria of biofilm and the prevention of its reformation, cleaning the food debris and stains. That's what we wanted. And it, along with the removal of the debris, there is massaging of gum tissues also. And sometimes you can use a toothbrush to apply the medicaments, which is unable to use your finger or your cotton swab where in that area. Then the brush will help us to apply the medications in that areas. Which is the most common question asked: is electric toothbrush are effective in plaque removal? Yes. There are a lot of studies, and this is a controversial question. So, effective or not effective? Yes, there are certain authors with study, they found that like a Cogna et al., Pirnain, and the Coates et al. Yes, the electric brush, power toothbrush is more effective than manual toothbrush. But likewise, there are certain studies that showed nothing is statistically significant. Here, the technique is more important than the rotation. There are certain differences between the electric and manual toothbrush. Because of these properties of electric toothbrush, definitely it is superior or is better than the manual toothbrush. Those are strokes per minute. We can concentrate how many strokes, how many rotations you can adjust in that, which you cannot do it in the manual toothbrush. And there is a pressure sensitive pressure indicators also. Yes, you should not apply more force. Yes, that you can standardize in electric toothbrush. And there is a timer. You should not brush too much and you should not wait too much of time, and it will affect on the soft tissues also. That you can prevent it in electric toothbrushes. Definitely the plaque removal, what the study shows that, and what are the company says that this is a more efficiency for the plaque removal, definitely. But the studies is not shown so much of differences between the electric and manual toothbrush, but it's fine. So there is a recent article published in 2018, that is International Journal of Implant Dentistry, the effectiveness and compliance of oscillating rotating toothbrush in patients with the dental implants is a randomized clinical trial. They found there is definitely, it's a compared between the manual toothbrush and the electric toothbrush. Yes, if you think about the bleeding and probing on implant areas, definitely it's reduced in the patients are using the electric toothbrush compared to the manual, but the pocket probing depth as such, no. So they found, yes, there is a little bit of differences in clinical implications of electric toothbrushes as well as manual toothbrush, but not so much of clinical significance. So there are multiple studies published comparing between there are high evidence studies about group according to they compared the manual toothbrush and power toothbrush. Most of the studies, not much statistical significance. Is one brush is enough to clean all types of implants? These are the most common questions. Yes, no. Because we are practicing in and out of implants now. So where initially used to bother about the paralleling implants, now we're going for the tilted implants. If there is no bone, we can taking the support from away from the jaw. All these things is happening. So that's the reason all the implants, it's not same. And one brush we cannot use for the multiple implant maintenance. So we should always keep it in mind about the what type of processes the patient is wearing. That makes a lot of differences. That makes how to choose the brush and how to choose the floss. There's a multiple variety of the toothbrushes available in the market for the implant purposes. These are the unitef brushes, multi-tip brushes with angulated toothbrush, okay, and as well as there is a new brush is available in the market with a LED light also. This is a beautiful study I'm going to explain in detail about these kind of the brushes. So these brushes is designed in such a way that you should go in the lingual side also, and you can concentrate more on the implant surfaces rather than just rubbing over the processes. So there is the article published in 2020 in a Journal of Periodontal and Implant Science. So this angled implant brush for hygienic maintenance, a full arch implant rehabilitation is pilot study. They compared the straight handle toothbrushes as well as angled implant toothbrush. Definitely they found the patients with experience with that is definitely when you use if the patient used with the angled implant, then definitely reducing the bleeding and probing, and as well as improve the oral hygiene condition, as well as the maintenance is quite good when you use the angled implant brush around the implants. This is a small video how the angled brush will help us to clean properly. Got some issues with the video. So at the end of the presentation, I'm going to show this video separately. And I already told about there is a new brush available in the market. They still the study is going on that the LED toothbrush, as this LED toothbrush is affecting on the P. gingivalis, which is the most common microorganisms, causing the periodontitis as well as the periimplantitis. So they are going to targeting on the along with the cleaning of the implant surface, and along with that, they're going to act on the portal gingivalis. There's a beautiful study this doing in a vitro study, and in fact they concluded this gives good result. So what exactly happens is, if you use some dye around the tooth, and if you activate that dye with LED toothbrush, so that these microorganisms or their pigmented cells, this called as a pigmented microorganisms, so that when you pass the LED light over that, then there is chances of killing those microorganisms also, along with the plaque control. And the next question comes, the interdental brush. Is the same kind of the normal interdental brush available in the market? Can you use it for the implant cleaning? Yes, definitely you can use it. But how to select the interdental brush is a challenging one. Most of us, we don't know exactly how to select the interdental brush to clean the interdental areas. Okay, so usually the company people will give the two varieties, that is a narrow space and broad space. So most of the times we'll end up with giving the narrow space, which is a no use at all. So when you select an interdental brush, there is a certain protocol you have to follow. So most of the companies, like if you go for the Curaprox, you always gives the one the probe, which is the color-coded probe. What exactly it means, when there is interdental space, you have to just insert into the interdental area where exactly it will fit, the snugly fitting, that is a color code. So for this, the patient has to buy this diameter of the interdental brush. Then only it will useful, then only it will clean the interdental areas. Otherwise, there is no use of that using this narrow space interdental space. If you take the very broad interdental space, it never penetrate into the interdental space. So you should always choose the appropriate size of the appropriate width of the interdental brush. This is most important when you select an interdental brush in implant dentistry also, because these brushes should go and it go on brush over the implant surface. Then only is useful. Otherwise, just going and coming, there's no use at all. It's one more small video. Some problem happens in the video. I'll just show all these videos after my presentation. And these shapes of interdental brushes, we know there is variety of shape and variety of sizes available in interdental brush, and which is the best shape for to maintain the implant. That's most important. So there is an article published in a clinical oral implant research regarding the interdental brushes. What are the surface teeth implant? That's what is the best shape of implant interdental brush you need to choose. This is a randomized controlled and double-blind crossover study. See, they selected the narrow space and as well as the wide space implant, the interdental brush that is a 3 mm diameter and as well as a 4 mm diameter. Along with that, there is one more brush called they used as a waist-shaped circumbrushes. The shape is totally different. It's like a waist shape. There's a broader, narrow, and again become broad. These kind of brushes will help us to clean interdental area, implant area properly compared to using the tapered or parallel interdental brushes. Okay, they found a very good result if you use the waist-shaped interdental brushes compared to the other what is available in the market. The picture clearly shows how you have to use the interdental brush. If you use the floss or if you use the interdental brush which is not fitting properly, it's not adapting properly to the interdental area, implant areas, definitely it won't clean at all. There is a lot of studies, again, compared between the brush and floss, which is the best. Okay, so to support this article, a lot of studies also is proven, multiple articles is published. There are certain articles published, the floss is better than interdental area and interdental brush is better than floss. Definitely, most of the articles have shown that the brush is much better than dental floss. So these are all the that is about the oral irrigation also. That is also important. Even oral irrigation also is helpful in maintenance of the dental implants, but it's not so effective if you compare with the internal brushes. This is also one video which is so this. If you're coming to the one more supporting article, is the interdental floss is a safe when you want to use it in implant maintenance therapy? Most of the studies find out, so say that yes, it's a safe, but if we have multiple implants with the joint crown, the floss won't help us much. Okay? And if there is an exposure of the thread, especially if the threads are exposed and the rough implant surface is there, then interdental flosses, rather than helping, it will damage more on the of the soft tissues, as well as the remnants of the interdental floss may remain on the implant surface, so that it may lead to the peri-implantitis or perimucositis. This is a case report around 10 implant. Then cases they published the case series. Okay, they found that when there is remnants, they showed them remnants of the interdental flosses or the dental implants where there is a threads are exposed. In this kind of case, in this type of the case series, we have to always use interdental brush rather than floss. So selection of the floss also is challenging when you're thinking about the implant maintenance. So whether the floss is good or interdental brush is good, that you have to take a call depending upon the quality of the soft tissues, depending on the presence of the soft tissues, depending on the exposure of the implant threads. So they've found in case of exposed surface implant surfaces in the peri-implant conditions may be jeopardized by the applications of dental floss, and hence the utilization of interproximal brushes or toothbrush may be preferred in those kind of cases. The other most common questions comes in the practice is, doctor, which is the best toothpaste I can use it, whether the normal tooth or implants? If we come to the implant maintenance, definitely toothpaste also make a difference. Because whatever the toothpaste available in the market are high fluoridated toothpaste. Others up to 1,500 ppm is its highest mark of fluoride in the paste. But for implant maintenance, you should not use more than 500 ppm of the fluoride content. You should always use less fluoride content of the toothpaste. So, and as well as abrasive agents, which toothpaste has got a more abrasive, definitely you should try to avoid those kind of the toothpaste. Okay, so there is an article is published about, once you know about the truth of the fluoride, there is an article published in the local journal about what all the fluoride, the toothpastes all in the market, each toothpaste, what is the concentration of the fluoride. Because this fluoride is effect on the tooth implant by changing the fluoride. When it may damages the titanium oxide passive layer. There is studies have proven that about the effect of fluoride and the implant. It may lead to the, it may affect on the, and it may lead to the titanium ion release also. When there is a fluoride is more than alternative toothpaste, you can think about oxygenated toothpaste, where it will not affect on the implant surfaces also, as well as it creates the anaerobic conditions, so that whatever the organisms response for the peri-implantitis, that's also you can taken care of in that area. So this is the article published in the Indian market, what all the paste is available and what are the content of the fluoride in the toothpaste. If you come into the mouthwash in implant dentistry, yes, you can use the variety of mouthwashes available in the dentistry, but you should try to avoid the more fluoridated mouthwashes. Again, here also. You can use chlorhexidine or you can use betadine mouthwashes. If patient can maintain it well, it's well and good. But the high fluoridated mouthwash is contraindicated in implant dentistry. So there are proposed guidelines. These are about the guidelines about after placement implant. There are proposed guidelines for immediate loading implants. If you place an implant, is there any proposed guidelines for how to maintain it? What are the diet your patient has to take, and how to maintain it immediate for immediate loading implants? So this article is published in 2015 about the hygiene and the dietetic guidelines for implant supported full arch immediate loading processes. There's a beautiful article about, is given in and around about hygiene, about the diet. We have to follow this the proposed, the protocol, what they're following in USA. That is about the hygiene and about diet. Within 48 hours, patient should not rinse with any other things. What the patient can use the chloroxine gel, basically. Right? And within up to for the 74 hours about hygiene, the patient can rinse after 48 hours, within 72 hours, you can rinse it, and you can use a gel also along with that. And within a 2 to 4 days, the patient has to rinse it. You can chloroxine, or you can use water instance, you can use a gel. Right? So basically within 48 hours, patient should not rinse. Patient used to use only the gel, that is, which consists of chloroxine. And after 3 to 4 weeks, after 2 weeks, patients start brushing it by using the soft brush. Right? Till there, you can avoid up to 7 to 8 days brushing. The later, what are the protocols? We had to go to the medium toothbrushes. You can shift to that after 8 week post surgeries. The diet, immediately after loading, you have to think for the diet within 48 hours, only cold, liquid, and semi-solid. In the 72 hours, you can go to the room temperature as a semi-solid food. Then after 2 days, semi-solid, and this consistency will increase. You can, after 8 weeks, patient can have the consistent diet. These are all the home care methods. If you come to the professional care, we know when you selected the instruments for the professional care, you should always think about implant surface, and you should think about our working edge. It should not be too bulky so that you will not distend the peri-implant mucosa. And it should be, most of the times we're always for the disposable are able to sterilize those instruments. And those instruments should effectively remove of the plaque and calculus without it doesn't damage the implant surface. This all criteria to select the implants for the implant maintenance in dental office. The most of the times you always use the plastic curates or plastic scalers, which will not damage on the implant surface. It will not give any scratches on the implant surface. If you use the normal curate, which is made up of the stainless steel, definitely is going to affect on the implant surfaces. It creates a lot of scratches, and it may lead to more plaque accumulation. So we avoid piezo surgeries, whatever the tips we're using for the normal piezo surgeries, definitely should avoid. You can use the tips along with if there is any coating, or you can use for the silicone tips. There is a new therapy for maintenance of the implants in the dental office that's called as a guided biofilm therapy. In this therapy, there are 8 steps are involved in that. That is, the first step is assessment of the patient and assessment of the soft tissues in the oral cavity. And second thing is you need to disclose the plaque. And the third thing is about education and motivation of the patient. And the fourth step is airflow, and fifth is the periflow. Then you'll go for the pigeon, that is using of the scalers, and going for the checkup at the 7th step. And after that, again, 8 steps to recall. So this guided biofilm therapy is helpful for the long-term success of implant, as well as maintain the good implant soft tissue integration. The first step is assessing the peri-implant soft tissues conditions in that bleeding and probing, plaque index, quality of gingiva, what is the correctness tissue, everything going to assess it. Then using the disclosing solution, what you use normally for the plaque disclosing. This is basically for education and motivation for the patient. What all areas is inaccessible, and what all areas more plaque accumulation taking place, and which area you have to give more stress to remove the plaque. Fine. So this is just basically for educating and motivate the patients. Right? Then we can use airflow. These are all the components of the EMS set. Right? So this airflow is being utilized with the erythritol powder. This is the small slurry powder will be there in the water flow, so that it will help to cleanse that area, and it will help to remove the whatever the debris as plaque over the implant surface. This basically you can use it as like an airflow or water flow stand-in. And this is a beautiful instrument which is also is there along with it's also in the company EMS. That's a Periodontist. You can put it in the subgingival areas to clean the implant. It spreads in the different way, like a 3-way syringe. There will be 3 spaces you give, that is mesially, lateral, as well parallel, so that it deprives this subgingival plaque, as well as is there any food debris. So this will helpful for the subgingival cleansing also. As you know, the 6th step, you can use the scalers, not use the tips. You can use for the coated, or you can use the silicone coated the tips to clean the pigeon. And seventh, recall the patient and recheck it and assess for the again the quality and quantity of the plaque and as well as soft tissues assessment. Then the eighth step is a recall. It's most important for again for education motivation for the patient as well as how do you maintain the implant surface. So the last but not least about the lasers in maintenance therapy, definitely the titanium brush and the diode lasers play a major role in implant maintenance also. And as we always knows about the cyst, that's cumulative interceptive supportive therapy. There's a cyst protocol by Mumbele and Lang et al. This all depending upon the probing depth, the pocket probing depth. If it is less than 3 mm, more than 4 to 5 mm, less than more than 5 mm, what are the things we need to do about this? We already know about that is about if there is any plaque index, we'll take up the plaque index, if you're bleeding and probing. And if it is less than 3 mm, we're not going to do anything, just to do the mechanical debridement and we'll polish that area and send it off. It's a non-surgical approach, we're going to do it. If it is more than 5 mm, then you have to think about the local drug delivery as well as the systemic or local antibiotics. And if it's more than that, then you have to think about resective or regenerative surgeries around the implant. So depending upon the classification of means depending upon the type of the implant defect, whether it is a class 1, class 2, class 3. So amount of the destruction, amount of the soft tissue and hard destruction you have to plan or you have to manage the defects. That is, if it is peri-implant, it is class 1. We're just going to initial therapy. Just we're not this here, the slight horizontal bone loss is happening in that area. So non-surgical therapy is more than enough. And if it is a class 2, if the peri-implantitis happen, it's happened in and around the implant and there's amount of the bone loss has taken place, that is moderate horizontal bone loss with isolated vertical defects, definitely will remove all the local factors and you have to open the flap, then debride it properly. And if it's vertical defect, you can go for the regenerative therapy and along with the systemic antibiotics. If it is class 3 peri-implantitis, here there's a more advanced horizontal bone loss with broad and circular bony defects you can expect. Here you can go for the surgical aspect by cleaning the implant surfaces and pocket elimination via osseous like regeneration techniques. So you can go for the PRP and you can use bone graft membranes just to guide this concept of GBAR you can think about in this case. And if it is class 4, we always plan for explant the implant because it's more than 50% of implant. The bone is lost around the implant. The last but not least, importance of keratinized tissue around the implant. So we place the implant in and out. We can place the implants here and there. When there is no keratinized tissue, they are more prone for the peri-implantitis. Even though there is no, even though everything is fine, but there is no place to maintain the oral hygiene. The patient cannot place the toothbrush in that area. And if their keratinized tissue is less, the studies has proven that they are prone for the peri-implantitis. So the need for the minimal amount of keratinized tissues is most important because increase in the plaque. Right. There's a clinical significance of attached gingiva around implant is most important to prevent the spread of inflammation, prevent recession of marginal tissues, and provide the tight collar around the implant, and as well as enable the patients to maintain good oral hygiene. So these are all clinical significance of attached gingiva around the dental implants. So is there any methods? Are there any methods to increase the width of attached gingiva? Definitely there are methods to increase the gingiva. That's called gingival augmentation techniques. So those are all about the denudation techniques, periosteal retention procedure, or split flap procedures, and there are certain procedures like free gingival graft using the gingival augmentation techniques. So these are all techniques they use, to increase the width of attached gingiva around the implants, so that there will be more keratinized tissues. So that's less plaque accumulation and as well as easy to maintain. Yeah, this is the case which is referred to me, where the patient was complaining about there is an implant, the threads were exposed. So what you have to do? Because when there is the implant surface is exposed and the implant the threads are exposed and there is a lack of keratinized tissue around the implant, So here the maintenance is very difficult for the patients. First thing is there is exposure of implants and as well as implant threads, as well as the lack of the keratinized tissues. So what we did is, you can see the angulation of implants is very bad. And what we did is just first and foremost, we tried to increase the width of attached gingiva, which was not possible in this case. What I did is just I just did the implantoplasty, the smoothen implant and smooth by using the burrs, and removed all the implant threads, made it smooth with polished with the paste, so that I made it's a plaque-free implant. Then I opened full thickness flap, exposed the bone, and it did corticotomies to increase the blood circulation and as well as increase the. Then I took a soft tissue I did a soft tissue augmentation around the implants, the connective tissue graft. Then coronally advanced the tissues. Then I covered with attached. Means I just increase the amount of the soft tissue on implant so that patient can maintain that area. This is a post-operative. Most of the times there will be shallow vestibule. This is a case, you can see there are multiple implants are placed, and you can see the amount of plaque accumulation around the abutment. It's not loaded still. It was not loaded still, and patient is unable to brush that area at all. And you can see the attachment of the soft tissues over the margin gingiva directly. So there is no place to keep brush, or there is no chance to maintain the implant in that area when there is a shallow vestibule and there is no keratinized tissue around the implants. So I plan to increase the width as well as to increase the amount of the keratinized tissue and as well as deepening the vestibule. You can see just away from the implant, or 2 to 3 mm away from the implant, we can just given the periosteal incision and just deepen the vestibule and taken the free gingival graft. This is the best way to prevent the reattachment as well as maintain to create the vestibular depth, to increase the keratinized tissue. So I've taken the free gingival graft from the palate and placed it in the recipient's bed and sutured it around the implant. And this is a donor site which I covered with the protecting appliance, that is A6. Then this is 2 weeks after the post-operative. Fine. So this is the donor site healing, and you can see amount of attached gingiva got it. But the problem is this disease is whatever the keratinized tissue got it around the implants, which was not fixed, it was almost mobile. So it is kind of or not success in these cases. Definitely I had to go for the re-entry into that area again. So you can see amount of keratinized tissue got it, but only thing is which was mobile. It's not fixed to the underlying periosteum. So now I have to go for the re-entry to that area, but it's a re-surgical entry. So again, I created one more vestibule depth away from that tissues, and I just deepen the vestibule, and I created a pouch where I can reinsert the whatever the attached gingiva I got it, whatever the keratinized tissue I got it, I just readapted to towards the periosteum, then re-sutured it, and this is what I got at the end of the result. So this was a pre-operative where there is no vestibule depth, there is no keratinized tissue, and the margin gingiva is always moving when the patient opens his mouth. So here good amount of the keratinized tissue got around the implants. Now patient can maintain that area peacefully, and now we can do beautiful processes around this abutment. The second case I used is mucoderm, where patient is not willing for the autograft. They don't want to go for the one more site of surgeries. And first thing, the second thing is where amount of the tissue is required too much, where you have to go for both sides, the right and left side of the palate. Patient don't agree in that case. So there's alternative material available in the market. This is called as mucoderm. This is a case you can see there is implant was placed long back, and there is no keratinized tissue around implant, as well as there is a shallow vestibule. You can see there's occlusal view as well as the frontal view. With measurement, you can see just only 3 mm of the depth of the vestibule you can notice. Because of that, you can see around the implant around the healing abutment, you can lots of calculus around the healing abutment. Fine. So this is about pre-operative. So what I did is just I need to do the increase the vestibular depth to enhance the more keratinized tissue around the implant. So I did the reflecting the partial thickness flap, and here this is an intact periosteum around the implants. I deepened the vestibule around more than 10 to 15 mm. Fine. So this is a huge area. The patient was not ready to. No, he was not willing to go for the second surgery for this. That's the reason we choose the mucoderm. Fine. So here I modified the technique a little bit. So I made the sub pouch between the implant also. So I created a pouch implant so that I increase the thickness of the tissues around the implant also, and as well as increases the depth of the vestibule around the implant. So I created a pouch around the implant, and I created this the vestibular depth around the implants. And this is a mucoderm. I placed the mucoderm, and just this is the stabilization suture. I stabilized the mucoderm, and just adjusted properly with the periosteum, and I closed the flap without tension. These are tension-free sutures placed, and recall the patient. This is just to protect the grafted area, and this is after 10 days of the healing. And these are the post-operative. Here, apart from getting the good keratinized tissue on the implant, I got the good amount of width also, and as well as height of the cord, height of these tissues also. So in all three ways, it was beneficial to the patient, and now patient can go for good processes over the abutment. So this is the third case here also. This is what I'm telling. Why I'm telling these cases is even in a periodontal maintenance, in implant maintenance, the keratinized tissues play a major role. Whatever the variety of brushes available in the market, whatever the new techniques available in the market to maintain the implant, when there is no keratinized tissue, it's very difficult to maintain it. That's the reason. So if it's not favorable conditions, you have to make the favorable conditions. You have to create the good amount of attached gingiva, it means the keratinized tissues. You have to create the good amount of vestibular depth so that patient can maintain that area. That's most important. If we're not creating that environment, you're not creating that situation, whatever the tissue is that it's not going to help us, it will not heal up, it will end up with it again. There's a constant perimucositis, and it leads to periimplantitis, or sometimes it goes for the failure of implants also. The implants are placed beautifully, it's also integrated beautifully, but there is no good amount of attached gingiva, means the keratinized tissue around the implants. Right? So you can see there is a lot of scar tissues formed. They already attempted twice. They attempted in different places. They attempted the free gingiva graft on that it didn't take up. There is a failure. So you can see there are a lot of the scar around the implants, and there is no vestibule depth almost the marginal gingiva attached to the vestibule. There is no keratinized tissue at all. There is no attached tissue attached gingiva at all in that area. You can see after removal of the prosthesis. When the patient moves, you can see there is a frenum attachment almost next to the neck of the implant. Fine. So in these cases, whatever the angulated the brushes, you can give the water floss, you can do the power toothbrush, patient cannot maintain this area. So what I did is just I need to increase the band of the keratinized tissues in that area, definitely. So to increase the vestibular depth from this almost around the 25 to 30 millimeter. It's almost their depth. So in this case also patient is not willing for taking the graft from the palatal area, because already twice they attempted, they could not get the good result, and so that's the reason patient is reluctant to go for the same kind of surgeries repeatedly. So I attempted. There is a new material available in the market. There's a biohorizon, which I'm doing the clinical research on these cases on this material, and this one I use it to increase the width of the keratinized tissues. So I did here also same thing. I created the little pouch. There's a supracrustal that is just next to the implant. I created a pouch. The supraperiosteal pouch I created between the keratinized tissue and supraperiosteal. And here there is the deeper incision given and reflected the tissues away from that. There is okay, and I stitch whatever the tissues reflect in the lip, the buccal mucosa to the underlying the lip itself, so that it will not rebound and reattach in that area. And whatever the sutures I placed, these are all anchoring sutures and stabilizing sutures. I didn't pierce the tissue. I didn't pierce any suture material to the tissue, means whatever the graft material. These are just stabilized without piercing those things. So these are stabilizing sutures or anchoring sutures. Fine. And this is after the 10 days of healing. Good amount of tissue is taken place. There not much of necrosed tissue at all, you can see, and the lip is positioned is over this. The case is still under follow-up. So the next Monday or Tuesday, I'm going to take out the sutures and leave it for another 2 weeks to heal completely. Then we are going to follow. So these kind of cases, this is a one way of helping the patient maintenance. So I can post of photos. I'll post it in your group later, whatever the follow-up cases. So by conclude, the long-term success of the dental implants requires the maintenance of healthy peri-implant tissues. This is most important, and periodic clinical assessment of the implant fixture, processes, and surrounding tissues is critical to clinical success. And a good oral hygiene and a regular professional care are essential to maintain implants. This is most important. The patient, along with the clinician, should involve in the maintenance of implants by following the stringent home care for long-term success of dental implants. Together with surgical phase of treatment, the implant maintenance and effective home care can consider as 2 other factors for implant success. So by this, I'm ending my presentation, open for the discussion, and thank you so much for giving me an opportunity to present whatever the knowledge I have over the implant maintenance.
Thank you so much, Dr. Mahantesh. It was really a great presentation. And we have some few questions. I also have few questions. So let me start with the questions people have asked. There's one question that how do we assess? How do we assess whether the patient has been complained with implant maintenance aids prescribed to him if he comes with compromised implants after 5 to 6 years of loading? I don't understand this. The patient can always say he has followed the instructions, but is there any way to know for sure? I think he's trying to ask that how we come to know whether the patient is maintained well and has he used the maintenance aids, but still is not able to get help from it.
This is a very good question, sir. A very good question. That's why I told you about the proposed protocol. So what I showed you, there is a nice research that done about the proposed protocol. What I showed you, the study, the ordinary and extraordinary. So each and every patient, you should recall 3 to 4 months interval for initial days. So that's how we'll come to know whether his maintenance is a good or bad. That's how we can educate and motivate him. You cannot say that I had given the instruction, whether he's followed or not followed, will not come to know anyhow. But patient has to report back to the dental office. Then he has to go through the routine dental checkup. Then only we can assess. Then only we can reinforce where went wrong, what went wrong, and what is the outcome. So basically, patient has to come back to us, sir. And clinical examination and radiograph examination is a mandatory for each visit. So that's the reason the success rate in Indian implant in India and abroad is a total mix. Because if you see, sir, you already know about how they will do the maintenance protocol in US and the UK or in Europe countries. They have a lot of the protocols. They have the software for everything they want to. They will assess each and everything, the soft tissues conditions. They'll assess for the peri-implant conditions. They'll assess for the plaque indices. Everything they'll maintain. They'll educate and motivate, sir. So basically, the maintenance is in both hands, the dentist hand as well as the patient hand. It's a home care as well as the professional care. Then only we can use the good success, and then only we can save the good maintenance therapy, sir.
Yeah. There's a next question. Brand name of implant toothpaste, if any, which has 500 ppm fluoride content. Also frequency of use of mouthwash. Can you just advise us? And he also asked me one more question. Are water jet flossers a good thing to prescribe for implant patients? Yeah.
Yes, sir. Sir, actually, the less than 500, I was after I read an article about the what all the toothpastes having the how much the fluoride ppm. Actually, this article is published in Mysore Journalisms in the JSS actually. So according to my knowledge, whatever the the Colgate, Pepsodent, whatever things are there, they are almost 800 to 1200 ppm. Okay, and I got more curious too. I started searching about is there any fluoride content in the Dantakanti or the Himalaya and all these things. They didn't mention properly about that. That is one thing I come across that. The second thing is for the implant maintenance toothpaste. Say already there is Blue M gel is available in the market, but it's quite effective. It's quite expensive. But it is not a regular paste. It's a therapeutic paste. When a patient comes for the checkup, you can use it that mouthwash, or it's available in the form of the mouthwash, is available from the gel, is available in the form of the foam. So where they can use it once in 3 months just to maintain the gingival health around the implant. And which is not available in India, but in abroad you can get it. That's called as a Implant Clean toothpaste. That's called as Implant Clean toothpaste, where there is a less than 400 ppm of the fluoride, so they can be advised for the implant maintenance. It's available in the online, sir.
Okay, that's a good information, I think. I have few questions, Mahantesha.
Sir.
Do we have a protocol set for maintenance of a patient with implant, a single implant separately? Then do we have a protocol for a full mouth maintenance, full mouth patients? Do you have a separate setup, something like that?
So that's what I initially I told about. Most of the protocols are proposed protocols.
Yeah.
Nothing is a concrete.
Yes.
And the maintenance for the single implant, the maintenance for the 2 to 3 implant, that is a kind of the fixed parcel, that is different, and maintenance for the full mouth is different, sir. Yes. So as such, there is no fixed protocol. So most of the things are is not it's all individual perception, as well as the dentist have to educate and motivate them. So yeah, I think we have to take up a study for this, sir, in your academy, so that we can create a nice protocol for the implant maintenance.
Yeah, I think probably. No, I was just asking, do you, as a periodontal faculty, do you teach postgraduates? And because now the situation where even a general dentist will come across many of the patients in his OPD which are implant placed.
Yes, sir.
Isn't it? So it will become a routine follow-up for every general dental practitioner or an implantologist. It's not only implantologist for particular. So do we in Indian periodontal scenario, we teach them exclusively for implant maintenance, or we have some protocols, I mean guidelines or something like that?
No, sir. Actually, that is the only thing. It's
so
the
don't
least.
Say no, because many periodontists will be listening, HODs and all that. So,
no, sir. Because actually we see in implant maintenance, say if you go to the Karans or some articles, they showed what instruments you have to use, how you have to use. Yeah. As such, according to mine, there is no concrete protocol for that. And there are a lot of companies that come up with implant maintenance kit.
Yeah. The Periodontist has it.
Yes, Periodontist has one. Yes, Periodontist has an implant maintenance kit. So in that they displays the variety of the and designing of the implant, internal braces, how to choose and how to all these things. So they are coming up with different implant maintenance kit. So, but it's not coming through with academic wise. Still, we have to take a call, sir. Yeah. But we teach the students how to brush. We follow all the oral instructions for the normal patients, but for the implant patient, we have to make a small protocol, and it has to come through the main things. Then only it will implement.
The association has to take a serious measure in that. The organization.
Yes, sir. Because so nowadays people will go for implant right and left, and everyone knows about that. Everyone has the knowledge about that. So most important now we have to have the knowledge about maintenance also. So otherwise the implant failure it increases. Yeah, the purpose of me talking about,
asking for you for a maintenance lecture was the same thing, that now it's becoming routine in everyday practice that they get patients maybe not done by them, but they
Yes,
may
sir.
get patients from somebody who has done an implant, and instead of blaming who has done it and creating an issue there, we need to teach the patients how to maintain that, and try to follow it up. That
Yes.
has to be essential. And in my practice, what I have seen is, when I give a tooth water pick machine to
Yes.
a full mouth patient,
Yes, sir.
usually they feel pain or discomfort or a burning sensation when they use it, when the attached gingiva is not around the implants.
Yes, sir.
And also have seen that when the patient comes back with inflammation, when I give water pick in a full mouth, when there is no attached gingiva. So I have made it a point now to tell them very minimal use of water picks sometimes when there is, or keep the margins open. Probably that was the rule of thumb in earlier days, because why I'm trying to tell you here is, we have advanced with various protocols of restoration like Marlow Bridge and
Yes.
many things. See, Marlow Bridge is not a hygiene friendly protocol.
Yes.
Yeah, so probably the protocols which were earlier used in 90s and 80s, where they used to keep a polished collar of in the full mouth and keep the margins little up sometimes, maybe slightly anesthetics, but it used to maintain it well.
Yes,
But
sir. Self-cleansing.
rather than today, I have seen multiple cases when we have a wraparound acrylic prosthesis, or we have a Marlow Bridge prosthesis. There is no protocol for the lab people to make. Their purpose is to just make sure that there is no space between the tissue and the margins, and that makes the food accumulate very badly, and that makes
Yes, sir.
it very difficult for the patient to maintain. And as you said in your presentation, that we are placing outright in and out implants in India. So probably,
Yes, sir.
probably we, the authorities like organizations like Implant Society of Oral Implantology and things like that, Indian Society. So these people have to make certain guidelines, stringently follow it, and send it to the practitioners of implant, saying that it's not just the restoration is important, maintenance and follow-up is very essential for the long-term success of an implants.
Yes, sir. So
Yeah.
I take an opportunity to what exactly be happy to be privileged to be a periodontist, because most of the perimplantitis case is challenging to manage those things, especially
Yes.
I was just told they place the implants somehow, but the maintenance is very, very difficult. So
Yeah.
they never bother about the soft tissue considerations. So
Yeah.
there the periodontists play a major role about the soft tissue, because the soft tissue play a major role for the maintenance. Soft tissue may play a major role for the hygiene.
Yeah.
So
Yeah.
that is where I feel nice, because I have plenty of cases about the implant. The whatever that's, if one wants to take out the implant, you can see lots of sloughs around the implant. The ginger color is changed. Wounds, profuse bleeding in the soft tissues, all
Yes.
because of improper prosthetic design. What you said. So if you maintain the self-cleansing area, definitely that will be easy. But only thing is aesthetic is an issue in that condition.
Yeah. Yeah. So that's
So
what.
that time the soft tissue play a major role, sir.
Yes. Yes. So as you said that the attached gingiva is very important, and you have showed us some cases of vestibuloplasty and making the enhancement of attached gingiva around the implants.
Yes,
I
sir.
think that should be more emphasis for the beginners, because nowadays what is happening is, when they select the case, the beginner or any implantologist, we call them, they only take in consideration the bone available there.
Yes.
That's the only thing they want, because if they
Yes,
have
sir.
a bone, then everything is there for them. So
Yes.
probably they forget to understand what is attached gingiva's importance, how we have to give a cuff, how the cuff has to be maintained, irrespective of a single implant or a full mouth.
Yes, sir. Actually, there is an article published, so I just forgot the author name.
Okay.
So there they found a survey. So most of the patients, you usually will think that most of the patients are coming to us for the occlusion, achieving efficacy. Nothing like this. 90 to 95 people are coming to a dentist for the occlusion as well as the aesthetic.
Yes.
So
Yes.
the soft tissue or the pink tissue also play a major role for the outcome of the tissue that we implant. So we should always keep it in mind. The soft tissue also play a major role, and always keep it in mind the importance of the soft tissue around the implants for the long-term success.
Absolutely. No, that's what I take this opportunity again to thank you. And I just wanted to present you with the token of appreciation, a certificate. I think you're seeing it. We will be sending you a hard copy of it.
Thank you so much, sir.
Thank you so much for your time and immediately agreeing it, because I had seen you lecturing about the maintenance in Gulbarga. So that is where I thought that you should speak to us, and probably our diplomats and fellows get enlightened with the thing. And thank you again for all the participants who are there here in this group. And any other questions anybody has, or we will sign it off? I think there's no more question. Thank you, Mahantesha, again.
Okay, sir.
Thank you so much.
Thank you so much, sir. Thank you so much for giving them an opportunity. In fact, because of you, I also studied so much, and I also got a little bit of knowledge. Otherwise, I wouldn't have gone in deep depth of this maintenance. So I also got some amount of knowledge.
Probably you should take it this as a now serious initiative to promote and educate many more dentists.
Yes, sir. Yes, sir.
Yeah,
yes, sir.
yeah.
Yes, sir. Yes, sir.
Thank you so much. Thank you.
Thank you so much, sir. Have a good day, sir. Thank you.